important. So we'll see the video today.
There is a standard operating procedure and an expected outcome. Similarly, in communications, there is an indication, there is a standard operating procedure and an expected outcome. Similarly, in communication skills.
Is it audible?
Yes, ma'am.
Okay.
None of us have time to waste. So the communication that we do, there has to be a reason why we are doing it. There has to be a method of doing it. And hopefully we'll get an expected outcome out of it. Today we'll be covering communicating bad news. We'll talk about some of the disclosure models. We'll also talk about why it is needed to communicate bad news. Then from there, we'll take a diversion to collusion management. And then we'll come back to communicating bad news. But this time we will try to learn how to do it. And thereafter, we'll also talk a little bit about anger management. So when it comes to breaking bad news, essentially it means telling the truth. And truth telling has never been easy. Back in the days of Plato, he had said that no one is more hated than the one who speaks the truth. So communicating bad news, breaking bad news is nothing but telling the truth. So who should tell, how it should be told, etc., etc. That is the that's the whole point that we are doing this session today. In most of our Indian setting, we do not tell the truth to the patient. Even if the patient has come with the family, most of the time the patient is asked to go out of the room while we communicate the truth to the family. And we may have different reasons for not telling the patient. And most importantly, we may not be comfortable telling the truth to the patient. That's why we would rather speak to the family than the patient. Now, the problem is, what if the patient wants to know? If somebody wants to know, it is their right. And therefore, this model, non-disclosure model, gets into conflict with the patient's right to know. Patient may want to know for various reasons, but if we deny them, then it is the conflict with the patient's right to know. In some countries, you are by law required to tell the truth to the patient, not to the family. You can, of course, talk to the family with the permission of the patient, but not otherwise. And in those kind of situation, what if the patient does not want to know? So there also the problem comes in that this method of full disclosure model gets into conflict with the patient's right not to know. So both these models, non-disclosure model and full disclosure model, have the problem that it gets into conflict with the patient's right to know or right not to know. Why? Because we are deciding whether the patient should be told or not. We are not really inquiring into what does the patient want. Therefore, a third model, what we will call individualized disclosure model, and here we will first figure out if the person sitting in front of us wants to know or not. And if the person wants to know, then we can tell. But then we need to also figure out how much the person wants to know. Because if we tell too little, it will cause dissatisfaction. If we tell too much, it may cause some emotional trauma. Therefore, how much is also important. Now, before we figure out all of this, let us talk about why it is important to tell the truth, why it is important to communicate the bad news. One, it will help the person to finish up whatever needs to be done. It will not happen immediately. As soon as the person hears the bad news, there will be some emotional trauma, they will be crying, and then there might be some bargaining, some anger, some depression. Ultimately, once the person comes to terms with his or her mortality and the fact that the time is limited, then at some point of time, the patient will decide on what I need to do. So, setting the finances in order, making sure that children's marriage or education or whatever that needs to be done for the family in whatever way possible is settled. May want to visit an old friend, or may want to do certain things which have been kept aside. For example, a bucket list. It is also important that you get time to improve your relationship with your loved ones. It's also an opportunity to mend relationship that have gone bad in the past. A time to forgive and forget, or to ask forgiveness. So a lot of things that can be done. It is possible to do. And if the patient does not know, all of these important things does not happen. Therefore, it is important to communicate bad news. Another area is that if the patient does not know, the patient's expectation is that I will get back to normal, because nobody told the patient the reality. So, from our point of view, the patient's expectation may be unrealistic, but from the patient's point of view, the expectations are very normal. And if we are not able to match up to the patient's expectation, ultimately the patient will feel frustrated. The patient will realize that we are not able to match up to his or her expectation, and therefore that patient will lose faith in us, trust in us, and therefore may demand to be taken some other place. The family will have to comply, even though the family may know the truth, but the family cannot tell the patient that no, you cannot go to other place, you have to stay here. The family cannot do it. So as a result, what happens is the family is forced to take the patient to a new place, and when the patient goes to a new place, the hope rises that now things will be better. But eventually, even in the new place, the hopes are crashed. The person expectation don't match up, and then after blaming the new place, the new doctors, etc., etc., the patient demands to be taken to another place, and then the fourth place and the fifth place. Eventually, the patient will start blaming the family that they do not want me to get better, and they are after my property. They wish that I were dead, and all those kind of things will create a lot of negative energy inside the uh, inside the house, inside between the relationship between the patient and family. And uh, and also because when you stay out of home, it requires money. Therefore, the expenditure just keeps on increasing, just keeps on going, because you're going from one place to the other, to the third place, to the fourth place, looking for a cure that does not exist, looking for treatment that does not exist. Whereas if the patient had been told, the person could have stayed at home and be comfortable with the help of palliative medicine, and could have made the best use of his time by finishing of things that he needs to finish, and in general, making the most of his or her life. However, that does not happen. A lot of time is wasted running around treatments that don't exist. A lot of money is wasted. Many a times the household is sold because of so much expenditure, and the patient ultimately dies, and the patient's family is literally on the road with nothing. The children's education goes, everything goes. There is so much of debt, so much of bankruptcy, a lot of poverty in our country is contributed by the medical profession. Then the third point is, when the patient has not been told, the family members are forced to act in front of the patient as if nothing is wrong. They put on a mask of normality and behave as if everything is fine. And then when they are overwhelmed, they may run to the furthest room in the house and cry, or they may run to the neighbor's house and cry, or the relative's house and cry over there, or they come to the doctor's consultation room without the patient, and then they cry in front of us. They obviously cannot cry in front of the patient because the patient has not been told. But the patient's body does not lie to the patient. The patient's body tells that I am not getting better. I'm having something terrible, and the patient keeps asking everybody, "What is wrong with me? Oh, I mean, what did the doctor say? Why are you not telling me the truth?" But nobody tells her to, and the patient also realizes they are not telling me the truth. And then relatives from far away, they start coming in to see the patient, and they stand at the patient's door with the hand on their chin, looking at the patient with a lot of sympathy, as if looking at a specimen in a jar. And most of the time, when people, uh, patients, see that their relatives are looking at him or her with sympathy, they just get irritated, they just get angry. And most of the time, they may end up getting angry uh, at their family. Why are you letting these people come into my house? Tell them to go away. And the family member is obviously helpless. They can't obviously say that to their relatives. The patient can hear the whispering going on in the next room, and the patient understands that they are talking about me, but they will not talk to me. It is like a wall, it's like a transparent glass wall. The patient alone on one side, and rest of the world, everybody on the other side. So all of these things are very, very traumatic to the patient and the family. And then the patient dies one day, and then the family looks at the photo on the wall and wish if only we had some more time with this patient. The question is, what were you doing when the patient was alive? That time we were playing a drama. We put on a mask and then we played a drama. So that is a tragedy, that when precious little time is left, you waste it by playing a drama. Instead of that, there was a time to say, I love you. There was a time to hug and cry. There was a time for all of that. But none of this happened. And somewhere we as medical professionals also need to take a part of that blame. I'm saying part of that blame, not full blame, because many a times it's the family members who come to us and says, please do not tell it to the patient. They come to us and try to collude with us, enter into a conspiracy of silence, that you talk to us, but do not talk to the patient. Of course, you can talk about the pain and breathlessness and anxiety and constipation and sleep problem and nausea, but please don't talk about the disease. So, this whole process where the family comes to us and says, please do not tell, that is collusion. And they do it because they want to protect their loved one from harm. And the harm, the perceived harm, is the patient knowing the truth. And they want to protect the patient from knowing the truth. And therefore, they need us for our services, but they're also afraid of us. They're scared of us, that we may inadvertently tell the truth to the patient. And they're very scared of it. And that's why before they bring the patient in, many times they will just come over and then come to our OP and say, we have not told the patient, please do not tell. So this collusion is something that the family most of the time initiates and tries to sustain with us. And many times we are also happy to keep up with this charade of conspiracy of silence, because we are also not very comfortable telling the truth to the patient. And most of the time, nobody taught us how to do it. And therefore, it seems convenient. The family said, don't tell. Okay, I will not tell. If you feel that it is in the best interest of the patient to know the truth, and if the family comes and says, please do not tell, do not challenge their belief, because they're already scared of you. And when you say, no, 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 it is important to tell it to the patient, you can, the patient will get a chance to finish their important things. You can prevent hospital hopping, doctor shopping, and, you can strengthen the relationship. None of this will go into their heads because they are so scared. They were scared to begin with. They were scared that you might tell. And now you are making their worst fear comes true. The worst fears have come true when you are saying, no, 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 it is important to say. So do not challenge their belief. They believe that it will harm the patient. So right now, focus on the family. In palliative care, we talk about relieving the suffering of patient and family. For the time being, forget the patient, focus on the family, and agree to collude. If the family says, okay, family says, doctor, please do not tell to the patient. You say, okay, no problem. I will not tell it to the patient. In my practice, apart from that, I also ask them, so what have you told him? So the family member will tell something that the lies that they have told the patient. For example, they may say, we are told it's an ulcer in the stomach and it will get all right with treatment. So then I'll say, okay, shall I also say it's an ulcer? And they'll be happy because now their fear has come down and they are happy that the doctor has agreed to collude. Now that does not mean they have started to trust you. That you have to earn. The trust you have to earn. For that you have to practice everything we talked about last time in active listening skills and how you show empathy. So there you practice all the active listening skills that you learned, listen to the family, and through that you build up a relationship. Another very important way of building up trust is to ensure that their loved one, that is the patient, that patient's physical suffering is taken care of. It is palliated well. If the patient was brought in with breathlessness, fever, nausea, vomiting, itching, whatever it is, the moment you put a smile on the patient's face, the family will find it easier to trust you. So, along with active listening, good symptom control will also help with earning the family's trust. So, once the family starts trusting you, the family will start listening to you. At this point of time, you can gradually bring in the topics of closure of life's business, hospital hopping, doctor shopping, barriers in relationship, gradually into the conversation and reorient the family and make them realize the importance of uh, telling the truth to the patient. Now, it initially you will experience a lot of failures, but the more you practice, the more you learn from your failures, and your conversion rates will improve. It will never be 100%. No matter how skilled you become, it will never be 100%, but definitely the conversion rates will improve. However, if you find that a patient's family is not agreeable, agreeable to your suggestions, do not make it an agenda. Do not make this your agenda that somehow you have to convince the family to let the patient know the truth. This is not your agenda. You can only try, because if you push it beyond a point, then the family members will think you have an agenda. They may become suspicious of your agenda, and then this will create friction between you and the family, and that will ruin the relationship. You cannot ruin the relationship at any cost. So you have to maintain good relationship. You have to avoid friction. Therefore, you try it gently, try to push a little bit, but if you find that there's a bit of a resistance, then don't try again. And there is no shame in failure. The only shame is in not trying. I repeat, there is no shame in failure. The only shame is in not trying. Of all the advanced communication skills, the hardest skill to master is managing collusion. So once we have managed collusion and the family members have given the green signal. In my case, I can tell from example, many a times the family members tell me, doctor, I can't tell this to him, so why don't you help me? So then in that situation, I offer my services and I tell them, sure, I will talk to him. But I also tell them that in case uh, your loved one, your son, your daughter, or your husband or your wife, whoever the patient is, does not want to know, I will not force this information on him or her. I tell this to the family members after I have managed the collusion. I get the green signal from the family to approach the patient with the truth. But I tell the family that I will tell only if the patient wants to know. I will not force it if the patient does not want to know. When it comes to now, we are coming back after managing collusion, getting the green signal from the family. Now we are coming back to communicating bad news. All over the world, the most common SOP is Spikes protocol. It is something that I am familiar with. So this is an acronym which stands for S stands for setting up the interview. You have to have the right kind of environment. In my case, if I am setting up in my OP, I prefer to do it in the evening time because in the evening, most of the OP crowd is gone. It is more quieter, it is calmer, and therefore it is the good environment for communicating bad news in the OP area. In the IP area, if it is in the patient's room, then usually time is not the issue. The only thing is when I am free. So that my time is the important issue because communicating bad news is an elective procedure. You have to find time because you don't know how long it will take, and therefore I have to make sure that I have enough time with me that I can spare when I'm doing it in the patient's room. Otherwise it doesn't matter whether it is morning, afternoon, or evening, but in the OP area I prefer it in the evening because it is quieter. Also, in the OP area, I also make sure that there is enough paper tissue because there usually some crying involved, a little bit of water, drinking water, and paper cups, etc. Some basic comfort I make sure that I have in my OP area. Then the next P stands for perception. Last time during our history taking, we talked about patient's insight. What does the patient understand about his or her medical condition? So that is very important that whenever we take a history, we don't know whether we will go into collusion management or communicating bad news. We don't know. But whenever we take a history, we must find out what is the patient's insight or patient's perception about his or her medical condition. And that is very important, especially in communicating bad news. Also, we have to obtain the patient's invitation, and that I will explain later. And then sharing of knowledge. And I told you we share knowledge in a simple language without Greek and Latin involved, so that the person receiving this information understand what's going on. And unlike normal sharing of information, when you communicate bad news, then this involves emotions. Once the patient understands, then naturally be prepared for emotions, and then we have to learn to deal with it. And once we have dealt with the emotion, then we can talk about the strategy and summary. Basically, what can be done, what cannot be done, where we have to go, what we need to do, etc., etc. That comes after we have dealt with the emotion. So essentially, this is the spikes protocol. Now let's go on to how we are going to go about it. For that, just a simple medical, just a case history. Mr. Bharat, who is a 60-year-old gentleman, 2 months ago started experiencing abdominal discomfort and weight loss. He initially went to the local GP and took some medications for about a week's time. And then after some basic evaluation, the local GP referred the patient to the gastro specialist at the city hospital. where some investigations were done. CT abdomen showed a mass lesion in the stomach, and OGD biopsy showed histopathology as carcinoma stomach. An exploratory laparotomy was done, which showed multiple peritoneal metastasis, and hence no specific surgical intervention was possible. They just closed the abdomen, and after a after a medical board, the patient was referred to provide symptomatic care or supportive care. Even today, most of the time I get a referral, the word palliative care is never mentioned because there is some stigma even among the medical professionals. They would rather use the word symptomatic care or supportive care. And now this patient is sitting in front of you. So this is basically the referral letter. In one para, you get all the information. However, when we talk to the patient, we have to, hear the story from the patient. This is also part of building up a relationship.
That's very bad.
Right. So we start this interview with the patient, comes and tell me, what brings you here, etc., etc. And then the patient says, you are saying that I have had gas since 2 months. So I went to the nearby doctor. He gave me some gas tablets, which I took for 1 week. There was no relief. Then I went back to him and he asked me to get an X-ray of my stomach. And after seeing that, he gave me a letter to see the gastro doctor in the city hospital. So the gastro doctor saw me and then he asked me to get a scan done and then a tube test. And after seeing all those results, they said that I need to undergo a surgery. But I didn't have any money at that time. So I went back to my village and I sold my cow and then I arranged some more cash from other places. And then once I had enough money, I contacted the hospital. They gave me a date. So I got admitted and then I got the surgery done. And after the surgery, they gave me this letter to come and see you. So this would probably be a typical story that the patient might say. However, we need more information. So bringing our history taking 2.0, let us dig for more information. So, hello, Mr. Bharat, come sit. Okay, tell me, what brings you here? So, Mr. Bharat gives me the reference letter. I go through it. It takes me 30 seconds to go through it. I understood the whole thing, but I now want to hear. So, Mr. Bharat, I read the letter, but I want to hear from you. Tell me everything from the beginning. When did the problem start? What all happened? Tell me everything. Well, I've been having this gas since about 2 months, and I went to my local doctor. He gave me some gas tablets, which I took for about 1 week, and I had no relief. Then he took an X-ray of my stomach, and after that, he asked me to give me a letter to go to the gastro doctor in the city hospital. Wait. Tell me, when the X-ray was taken, what did he tell you? What was the result? What was there in the X-ray? X-ray, I don't know. Doctor did not tell me anything. Okay. Then why did he refer you to the city hospital? Why did he ask you to see the gastro doctor there? Well, I guess since I was not getting better, for better treatment. Okay. Then what happened? Well, the gastro doctor did a scan and a tube test and then told me that I need to get a surgery done. Okay, so after the scan, did he tell you what was the scan result? What was there in the scan? Well, I don't know the result. They said something, but I did not understand. Okay. Then the tube test. Then what about that? What was there? What did they tell you about it? That also I really don't know. They said something. I mean, they were saying it in like English, and I really did not understand it. Okay, did they tell you why the surgery was required? I mean, what was the requirement of the surgery? No, they said surgery is required. So that was the treatment. Okay, then what happened? Well, I didn't have any money, so I went back to my village. I sold my cow, and then I arranged some more cash from other places. And once I had enough money, then I called the hospital and they gave me a date for the surgery. And then the surgery was done. And after that, they gave me a letter to see you. So, what did they tell you after the surgery? What was the problem? What was the surgery required for? Well, after my surgery, my gas problem is gone, but I'm feeling more and more tired each day. So that is they told me that you take this letter and come here. Did they tell you why they were referring you to me? Well, I guess for rest of the treatment, for better treatment will be here. So when you dig for information, when you ask more questions, then you realize that patient has a lot of blank spots in their understanding about what is happening to them. They may know a few things which are right. Some of the things that they understand may be totally wrong, but a large chunk of their insight would be blank. And that is very important for us to know, because this information is not good enough. This information is important because it gives you the medical story. But this patient story is not good enough. We should always try to get history to also find out, which is inclusive of the patient's insight, the patient's perception. What does the patient know about what is happening to him or her? So, this kind of history taking is something that we should do on a regular basis. Not because you plan to do plan to communicate bad news or something like that. This should be the standard history taking, where we find out the patient's insight apart from the rest of the story. And this I already mentioned, that how we prepare ourselves for the procedure. And if you have a patient who is already asking you all the time, what is my problem, what is my problem, doctor, then you don't have to explore, because the patient himself or herself is curious. However, you may have a patient who is really not asking any questions. So we don't know whether this patient is curious or not. So for that, you can do an exploration. Mr. Bharat, you told me that you continue to feel tired. Do you wonder why? Or maybe you can ask, apart from that, do you want to know more about your disease? And the patient may reply something like, yes, I want to know. However, if the patient by their own, if they're asking what is my problem, or on exploring, the patient says, yes, I want to know. In both situations, you cannot start telling them their problem. You cannot start telling the truth. You have to first give a warning shot. The warning shot has two purposes. One, the moment you give a warning shot like, Mr. Bharat, if it is something serious, would you still want to know? The moment you give a warning shot, suddenly a normal interview will turn into a serious atmosphere. The atmosphere will suddenly change into a serious mode. And it will also, the second thing, it will give an opportunity for the patient to rethink whether he or she really wants to know it or not. Therefore, it is very important in communicating bad news. The turning point, the most important point is warning shot. And this you have to practice to get it right. Because in real life, when you never know at what point you're going to say, but when you say it, it has to come clean. There should be no confusion. There is no beating around the bush. You have to say it confidently and cleanly. There should be no confusion in the message. In Hindi, you can say, Mr. Bharat, अगर बात कुछ सीरियस है तो क्या फिर भी आप जानना चाहेंगे? In Malayalam, you can say, Mr. Bharat, കാര്യം ഇത്തിരി സീരിയസ് ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? That's only two language I know apart from English. So I'll repeat in English, Mr. Bharat, if it is something serious, would you still want to know? And then if the response is like this, no eye contact. Remember, body language is the major component of any communication. If there is no eye contact, do not proceed. There may be no eye contact or minimal eye contact, and then the patient may give an excuse. Oh, just give me my medicines, I'll come back after 1 week. Then also it means that the patient does not want to know. Or the patient may divert this to tell it to my wife, tell it to my husband, tell it to my children. So that is also telling you that I don't want to know. But sometimes the patient, after hearing the warning shot, understanding the seriousness of the nature, may tell you directly, no, I don't want to know, leave it. Either of this situation, any of this situation, do not proceed. However, after hearing a warning shot like this, if the patient looks into your eyes and says, yes, I want to know, then there is no confusion. Here is a patient in front of you who really wants to know. Only then you proceed. So that is how you fulfill the first criteria of individualized disclosure model. You have to find out the person sitting in front of you really wants to know or not. If the person really does not want to know, do not proceed. If the person really wants to know, only then proceed. So once you have identified the type of person sitting in front of you, then how do you proceed? You tell a story. This is called a narrative style, storytelling. You tell the story of the patient to the patient from the beginning of the problems. In Mr. Bharat's case, since 2 months. And while you're telling the story of Mr. Bharat to Mr. Bharat from the beginning, you fill in the blanks. Remember, you know where the blanks are because the proper history taking has given you the patient's insight, and you know what all Mr. Bharat knows and what all Mr. Bharat does not know. So you tell the story of Mr. Bharat to Mr. Bharat from the beginning, and you fill in the blanks as you go along. And while you're filling in the blanks, you gradually escalate the information. And you watch Mr. Bharat's eye contact, you watch Mr. Bharat's body language. It's at some point of time, the eye contact stops, you pause the story because it can happen that you have given a totally new information to Mr. Bharat, and the person is trying to process, has swallowed the new information, is now trying to digest the new information. So at that point of time, it's possible that Mr. Bharat may not make eye contact, may be thinking and may forget to make eye contact with you. So give pause and just wait. And after some time, Mr. Bharat may make eye contact and ask you another question. Okay, then what happened? Then you can proceed with the story. It is possible that after getting some more information, Mr. Bharat may break eye contact, may not look at you, and now you are confused whether the patient is digesting new information or the patient had enough. And if the pause is becoming very, very, very long and you are becoming uncomfortable, then you can break the pause by asking a question, whether he wants to know more about it or not, or maybe what are you thinking, Mr. Bharat, or something like that. So if that breaks the spell and the patient again make eye contact, then you can continue the story. If not, despite your effort to try to break the pause, the person refuses to make eye contact, then perhaps the patient had enough. So you can stop the story at that point of time. So this way you are giving the right quantity of information, not less, not more, but just enough of what the patient wants. So stop whenever the patient wants you to stop. And at any point of time, it is possible that the patient may show emotions. And when that happens, we will deal with it. So a small role play for you. So after giving a warning shot to Mr. Bharat, Mr. Bharat, if it is something serious, do you still want to know? And Mr. Bharat looked me in the eyes and said, yes, I want to know. So from there, the story proceeded. Mr. Bharat, you have been suffering from gas since about 2 months, right? And you went to the local doctor and he gave you some gas medicines which you took for about 1 week, but you did not get any relief from it. So I remember you told me that your local doctor asked you to get an X-ray done. Well, the X-ray showed something like a shadow. And to know more about the shadow, he referred you to the city hospital. Oh, I didn't know that. And in the city hospital, they asked you to do a scan, and the scan showed something like a tumor. And to know what this tumor was, they did the tube test called endoscopy. So if you notice, initial filling in the blanks is something like a shadow, and in the next line, it is no longer something like a shadow, it has been escalated into shadow. It is no longer something like a shadow. And after that, in the next line, shadow becomes something like a tumor. And the next line, something like a tumor becomes tumor. So in Hindi, we can say, X-ray में परछाई जैसा कुछ दिखा, और ये परछाई क्या है जानने के लिए आपको सिटी हॉस्पिटल में भेजा गया. वहां पे स्कैन करने पे गांठ जैसा कुछ दिखा, और ये गांठ क्या है जानने के लिए आपको ट्यूब टेस्ट करने को कहा. എക്സ്റേയില് നിഴല് പോലെ എന്തോ കണ്ടു. ഈ നിഴൽ എന്താണെന്ന് അറിയാൻ വേണ്ടിയായിരുന്നു സിറ്റി ഹോസ്പിറ്റലിൽ വിട്ടത്. സിറ്റി ഹോസ്പിറ്റലിൽ സ്കാൻ ചെയ്തപ്പോ മുഴ പോലെ എന്തോ കണ്ടു. ഈ മുഴ എന്താണെന്ന് അറിയാൻ വേണ്ടിയായിരുന്നു ട്യൂബ് ടെസ്റ്റ് എൻഡോസ്കോപ്പി ചെയ്യാൻ പറഞ്ഞത്. So now eye contact is there, so we proceed with the story. The tube test was done to see if your tumor was something like a cancer or not. Cancer? Do you mean to say that I have cancer? I'm sorry. Yes. Mr. Bharat, do you want to know more about this? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened up your tummy, they found that the cancer had spread all over. They unfortunately could not remove it. They lied to me. So the tears have started. The emotions have started. So emotion need not always be in the form of tears. They lied to me. It can also be in the form of anger. Whether it is tears or it is anger, both are emotions. And when patients start expressing emotions, what you need to do is this. Don't say anything. Don't do anything. Just be with the patient. And as doctors, this is the hardest thing for us because all through our professional lives, we have been trained to do something. However, remember that many a times it is important to just pause whatever you're doing. When patients are ventilating emotion, just be there with them, focus 100% on them. Don't attend calls, don't check your Facebook, don't check WhatsApp or Insta, whatever. Don't say anything stupid, don't try to say things like, don't worry, I am there, we are there. Don't do any of that. At best, if you feel confident, you can touch them for a moment, then take your hands off, but just be there. Human beings need another human being to ventilate. And if you try to reassure at them at this point, all that they were ventilating will stop. And that is not what we want. We want them to ventilate completely so that then their brain will be ready to hear rational thoughts. When the emotional part of the brain is in state of hyperactivity, you cannot have a rational conversation. The cognitive part of the brain is always weaker than the emotional part of the brain. So you have to allow the emotion to flow. Then later we can talk. While patients are emotional, they may ask you some question. What did I do to deserve this? I am so afraid. I am so worried. Or how much time do I have, doctor? So whenever people say something, especially when they are in a state of heightened emotion, do not assume why they are saying this. Always ask, why did you say that? And then they will tell you why they said that. My daughter's marriage is fixed after 6 months. Should I prepone it? So here is a patient who said, how much time do I have, doctor? Because the patient had to plan something. There could be another patient who says the same thing. How much time do I have, doctor? Do not assume why this person is saying this. Ask, why did you ask that? Why did you say that? And then the patient says, why did God do this to me? So here is a patient who needs to ventilate more. So the same question, two totally different reasons. And if you have 100 people, the same question, there will be 100 different reasons because people are individuals and their individuality comes up when they say something. So the same things, how much time do I have? Why did God do this to me? All these kinds of things, you cannot assume why people are saying this. You have to ask. And when people tell the reason, many times you may not have a solution to it. But the only thing that you have encouraged is allowing ventilation, helping people to ask questions, and hearing them is a part of therapy. Clinical psychologists charge hefty fees for doing that. We, of course, have to do it free of cost. But please understand that allowing ventilation of emotion is part of therapy. Do not assuming and asking people is for you to get the right information, because wrong information is going to get you into trouble. Always get more information, but the right kind of information. And after all the ventilation has been taken care of, now you can talk about what can be done, what cannot be done, where you have to go, etc., etc., etc. And you can finish by giving realistic hope. Remember, never to give false hope. So decision, as we talked earlier, has to be participatory decision making, where we talk about with all the parties concerned, and together we make a decision by consensus. So that is about how to finish communicating bad news. Now, managing anger. Most of us different from law and order situation, and I'll tell you the difference. If there is a big gang of people, 10, 15, 20 people who have come to attack your hospital and you, then that's a law and order problem. We as doctors are not trained to deal with it. Even if you are given a lathi, you cannot use that to break somebody's head or somebody's leg, even if you have it. And even if you have a gun, you will not know how to fire it and injure somebody with it. And even if you know, I doubt whether you will be able to do it. But those who are trained for it, then they'll be happy to break somebody's bones with a lathi or injure somebody with a gun. So leave those. So run for your life, because you can always once you're alive and in good health, you can always help more people, especially yourself and your family. For their sake, do not try to be a hero and try to deal with the big crowd which is angry. The same applies for somebody under the influence of alcohol or the other substance, because you cannot reason with people who are not in a state of mind to be reasonable. So no point trying to manage an angry situation when somebody is under the influence of alcohol or other substance. So basically, what I'm talking about is a situation where you hear angry voices in the emergency area, casualty or ER or ED that we call emergency department or emergency room, or outside the ICU or outside your OP area as well. So wherever. So anger is a negative emotion which consumes a lot of energy. So to understand the source of energy, if you confront somebody, the confrontation can be in the form of argument, or you're trying to explain, or you're trying to apologize to somebody who's very angry, or you're trying to find excuses. Anything and everything can become confrontation. Another source of energy is when you ignore the angry person. You may be scared or you are plain arrogant, by whichever way. If you are not making eye contact with this person, you're turning your back to this person. All of this will constitute ignoring that person. So whether you confront or you ignore, both can increase the anger of an angry person. So people don't plan to get angry; they just become angry uh, for various reasons. Maybe they got stuck in the traffic for a long time, and they brought in their loved one who has been very sick or in pain, and they are unable to bear with the suffering of their loved ones, and then they had to wait a long time in the hospital, and probably somebody who came later got VIP treatment according to them, was called in earlier, and they continue to wait. So many things can trigger anger, but please remember, it is an accumulation of stress that finally blows up in the form of anger. It is not usually one reason, it is an accumulation of stresses, accumulation of stressful reasons, which ultimately blows up into a volcano of anger. And you can easily diagnose an anger by the facial expression of the patient. The eyes are usually bulging, the teeth are bared. Many a times you can clearly see this expression, and there would be so much of adrenaline in the person's body that the person cannot sit down. The person would be either standing or pacing around in fury, and the volume of the voice would be very high. The pitch of the voice can be shrill, and the content of the speech can be unparliamentary. The person may be questioning your genetics and your parents' genetics. All of these things may be part and parcel of a angry situation. So if you're dealing with this, then you know that you're dealing with somebody who is angry. Anyway, without even this, you will know that you're dealing with somebody who is angry. So what do you do? Now, here in anger, the major portion of anger management is body language. So when you might have seen WhatsApp videos where you see that doctors being assaulted or the hospital being vandalized. Many times when I watch these videos, I see often that you see the doctor is sitting behind a desk and arguing with somebody, with a group of people who are standing, two or three people who are standing. Then gradually more people join in. And then eventually the arguing just escalates, and then somebody jumps on the doctor and starts beating up. So important thing is that when you sit and communicate to somebody who's standing, you are creating hierarchy because your eye contact is not at level. So since you are the doctor and you are sitting and talking to somebody looking up, and therefore you are creating this hierarchy that I am superior, you are inferior. So to create equality, the moment you see somebody is angry, then you also stand up and create equality uh, by making the eye contact at level. So basically, the angry person cannot sit down because there is so much of adrenaline. That person cannot sit down. And when the person is very angry, if you tell the person to sit down, that will turn into confrontation and it will increase the anger of the person. So never ask an angry person, somebody who is very angry, to sit down. It may be counterproductive. It will make the person more angry. So you stand up, and this will equalize the eye contact. It will create equality. So this body language is sending a positive message. I see you as my equal. So the message of equality is sent by your body language. You don't have to say anything. Your body will say that. Then when you're standing, stand with a slight kyphosis. Remember, body posture, slight kyphosis is creating this message that I am here to listen to you. That is a respectful way of standing. Don't exaggerate it like the old Air India Maharaja's position. Just stand with a slight respectful kyphosis. So this is conveying message, I respect you and I'm here to listen to you. Then also keep the hands where the person can see it. Do not put it in your pockets if you wear trousers. Do not keep behind your back. Keep it, either you just let it hang loose in front of you, or just you can bring it in front of you as in the picture. Because there is this human psychology that when you are angry, you are in the fight and flight mode. That means you are angry, at the same time you are scared. You are afraid and angry, fight and flight mode. Now in that situation, when you show your hands, that means you are showing that I am not a threat to you. Now in the brain of the person who is angry, the person is seeing that the hand does not carry a weapon. All over the world, showing of hand is a gesture that I come in friendship. I do not mean to harm you. I am not a threat to you. Be it namaste, as in India, or showing of palm, or high five, or hello gesture, or that high gesture, a shaking of your hand, or as in the armed forces, you show hand in the form of a salute. All of this showing of hands is showing that I do not carry a weapon. I do not intend to harm you. I am not a threat to you. I come in friendship. You don't need to be afraid of me. So that is the importance of showing your hand to your to the angry person in a subtle way. So this, you stand up, you stand with a slight kyphosis, and you keep your hands where it is visible to the angry person. So these three messages you are conveying through your body. Now that is not enough. Let us focus on your face. You make eye contact. Obviously, don't stare. Unlike this picture, you keep your eyes normal, but you make eye contact. When you make eye contact, you are showing that I am confident. I am not scared of you. Now that is a message, but that should not be an arrogant stare, because then it can be counterproductive. Have a normal eye contact. But in here, keep your face serious, because you are showing that I am taking you seriously. Do not smile, because smile will be seen as confrontation. So this is one situation where I would not recommend smiling. You make eye contact and keep your face serious. And just like previous sessions, I encourage nodding of head when that person is ventilating. Basically, you are allowing this person to ventilate more. Remember, previously we said that to encourage the person to talk, you make eye contact, you nod your head and say something encouraging sounds like aha, okay, go on. But here you do not make any sounds, you do not say anything, just make eye contact, keep your face serious, and nod your head. Going back to body, stand up, slight kyphosis, keep your hands where the angry person can see your face, eye contact, serious, nod your head. And you are not saying one word, you are not making one sound. With this, you are neither giving this person any fuel for confrontation, neither are you ignoring this person. So you are cutting off the fuel supply to this person. Therefore, the severe anger will start falling rapidly, and you will see that the facial expressions gradually start to change. The person may be pacing around, now stops pacing around, is standing in one position. The shoulders may come down, the body seems a little bit more relaxed, the volume of the voice comes down, the pitch starts becoming normal, and the context and the words that are coming out becomes more normal. There will be less of cuss words and things like that. Now, that does not mean the anger has gone away. From high flame, it has come down to simmering flame. So the anger is still there. It can become more, but right now, from a dangerous situation, it has now come to a manageable situation. At this point of time, you can now open your mouth for the first time and then say, can we sit down somewhere and talk? I want to know more about this. Basically, you are saying, ye dil mange more. You didn't have enough of all this. You want to know more about this. So, when you at this point of time, you say, can we sit somewhere? I want to know more about this. Then basically, you are doing two things. One, you are removing this angry person from the public space. Now, why it is important? Because everybody and anybody who comes to the hospital, they come not because they want to come to the hospital. After all, you are not showing a movie, it is not a resort, it is not a happy place. So people come to the hospital, they come to see doctors because they are sick, they are not well, they are ill. It is a negative thing. So everybody will be stressed. The patient will be stressed physically and emotionally. The family members will be stressed emotionally, financially. A lot of stress is anyway there. So when you see one person getting angry and spitting fire in the public space, usually everything comes to a standstill. People stop walking around. They just stand where they are and they keep watching what is going on. And remember, this is a dangerous situation because emotion are contagious and everybody is stressed. And you see one person who is severely angry, spitting fire, loud voice, angry voices. This is a recipe for disaster because if you don't contain it fast, then other people who are already stressed, they will also start getting angry. So you need to contain this high flame anger, bring it down, and remove this person from the public space into a private space. The moment this person is removed from the public space into a private room, then whatever happens in the public space gets back to normal. People start walking, moving around, going from this place to that place because the tamasha is over. There's nothing else to see. Therefore, you have averted a major crisis by removing this angry person from the public space. But to remove this angry person from the public space, you have to first bring down the high blazing anger to a simmering anger. Only then can you take this person into a private space by telling this person, sir, I want to know more about this. Can we sit down somewhere and talk? Then take this person into a private room, whichever room is available. You go and get this person to sit down, and then don't sit behind a chair. Sorry, don't sit behind a desk. You pull up a chair so that you can sit face to face with this person, or at least at an angle to this person. Do not sit with a desk between you, because this is creating a barrier and this is going to be not satisfactory. There, and also this person will not be able to see your body, because when you sit down with this person, you have to continue your body language, except that now you are not standing, you are sitting. You are sitting, the angry person is sitting, so the eye contact is at level. You are continuing to make the from the with your body language, you are continuing to send a message. I see you as my equal. I am creating equality between us. And while sitting, you sit with a slight kyphosis. You don't sit relaxed with your back to the back of your chair. You sit with a slight kyphosis, because you are continuing the message that I am here to listen to you. And keep your hands uh, either on the table if you're sitting at an angle at the table, or if you're sitting face to face, keep your hands on your lap, wherever, so that the person continues to see your hand, because at a psychological level you are giving this assurance that I am not a threat to you, you can relax. And then you continue make eye contact, you continue shaking your head, and you continue listening to this person without interrupting, and you allow this person to ventilate, talk, ventilate, so that all the anger is drained out of this person by letting him talk and finish with the anger. And many a times, in my experience, when they have talked and done with the anger, many a time they then apologize and shake hands and apologize profusely before giving. Now, the advantage of you listening for this is that you will also get to know the story, what made this person angry, and there can be a situation where you can do something for this person, and that is a great thing. It will be a bonus. However, it may be a systemic situation where you really can't do much about it, because that is the way things are, and then obviously you will not be able to find a solution for it. And if there has been a situation where an apology is required because it was something that should not have happened, give a genuine apology. However, just because somebody got angry does not mean you have to give apology. Don't give half-hearted apologies. Don't give apology for the sake of it. If it is merited, do give it an apology. So that is how we end it well. If there is a solution to the problem which made this person angry, give it. If there is no solution, then you don't have to talk about it. If an apology is merited, give a sincere apology. Never give an insincere apology. It may make the person angry again, or at least it will leave a bad taste in the person's mind. So, for example, thank you for bringing this to our notice. We are very sorry you had to experience something like this. Thank you for bringing this to our notice. So this is what we are going to do. I'm going to talk to the operations manager and make sure that these kind of things don't happen again. So you can end by thanking that person with an apology or without an apology. So to finish off the last slide, when it comes to collusion, listen to the family, build up a relationship with them, and try to reorient them. Perhaps the most difficult of the skills that we talked about today. When it comes to telling the truth, remember your job is only as a facilitator of information. Your patient will decide whether they want to know or not, and they will decide how much they want to know. You just have the information. You are only a facilitator. It is not your job to give them information. It is for them to take it from you. Ventilation of emotion is therapy, whether it's in the form of tears or in the form of anger. It is not a waste of time. It is therapy. And specifically when it comes to anger, non-confrontational active ventilation of anger emotion is a comparatively of the three the easiest skill to master. So I'll stop.
Okay, so we have completed today's session, communication, breaking the bad news. So hope you have understood the important points that has to be remembered while we are breaking the bad news. So collusion is an important topic which we have to deal with the patient while we are communicating it. So once we have the green flag that the patient has the desire to know about the disease condition and its prognosis, so we will be going forward with the communication steps, right? So is there anything else that has to be cleared? Any doubts? Then I would like to know about the take home message, what you are taking from this session. So what are the important points you are taking home after this session? Anyone can respond. There is an unmute button in your phone or laptop. You can unmute it. So can you on your
ma'am.
videos? Yeah,
Yes, ma'am. To listen to the patient attentively.
yeah. What all
And
important, what is spike protocol? While we are breaking the news, there is a protocol that is called as spike protocol, right? So S4, what is it? S is setting, right? Setting, that is where you have to sit and communicate. It should be a private area with a comfortable and non-threatening setting. Then P for perception, right? Perception is what? Perception is what? Anyone? Perception is their understanding, what they know, the caregiver and the patient who has, or the family, what general idea they have about the disease, right? So when we are, while we are setting, we need a place where we have to communicate, so that is called setting. Then perception, we have to get an idea or understanding about, yes Karuna, understanding of the disease condition or prognosis, what the patient and the family they have in their mind, or they have anything in their mind that they have figured it out, this is happening to me or my patient, right? Then I for invitation. Invitation is ask the patient what they want, would like to know. Means we will give an invitation that the patient want to know. Yeah, will they want to know what things like how the disease is impacting them, or what is the end result of the disease, right? Prognosis of the disease. So these all things has to be like we have to ask to the patient. So when we get an invitation that they have the desire to ask, they have the desire to know about that disease, what we'll do, we will give a explain about the disease, that is knowledge sharing. The K for knowledge sharing, that is explain the disease and care options in normal language. That means if we'll use any kind of medical terms, they won't be able to understand. So normal layman language, what they can understand, we can go forward with that language. And then E for emotion. So as sir said, emotion means we have to, if the patient, when they get to know about their disease condition, they would be reacting either in a crying manner or in an anger manner, right? So we have to manage it effectively, right? Then after the emotional feeling, that is we have to respect their feeling, and we have to have an empathetic behavior. And also finally S for summarize, that is we have to recap everything and then decide what's the next step to be taken, right? So these are the spike protocol, which is very important while we are breaking the bad news. S for setting, P for perception, I for invitation, K for knowledge, E for emotion, and S for summarize. Hope this is clear.
yes, ma'am.
Okay, this is very important. You have to remember this. while, because in palliative care we will be, that one session will be there where we will be normally communicating, and then finally when the patient will be in our control or in our area, like they are getting an IP admission or we are going to the home visit, right? Or when OP time, we rarely get the time to break the bad news. So either in the admission procedure or while we are going the home visit, we can do these all things, because these are all time consuming, and also we cannot hurry the communication in a crowded area. So it should be in a private area with complete confidentiality, right? So these are the important things. And what do you mean by collusion? That is, the patient is not having knowledge or having general idea what the disease condition is and what's its prognosis, right? So collusion will be positive, and in that case, right? So so we'll end the session for today. Hope you have cleared it. If you have any doubt, you can text us in the WhatsApp group. Thank you so much for joining.
Thank you, ma'am.
Thank you.